So I'm going to jump back for a minute because we got distracted by oligometastatic disease, but I want to talk a little bit about something that has really been groundbreaking, I think, in oncology as a whole, and we are utilizing it quite a bit in colorectal cancer patients, which is ctDNA. So I want to talk about it first in the adjuvant setting. So I can give you my opinion, but I want to hear from all of you first. Tell me how you're incorporating ctDNA into your adjuvant patients.
So Arvind is the ctDNA.
Yes, I would say there's someone at the table that should speak first. Yes.
Well, thank you. That's very kind of you. I think the biggest benefit that ctDNA provides is that it's such a reliable and such a highly prognostic tool. If you were to take the example of stage 3 colon cancer, the way we approach it right now is that everybody gets adjuvant therapy. So everybody is getting toxicities from this therapy, but in reality, we're only helping 2 to 3 out of every 10 patients we treat with adjuvant therapy, with the rest either not needing it because they would have never recurred, or they're just not responding to the current standard of care for adjuvant therapy that we have currently. So what's the fundamental issue there? It's because we don't know how better to prognosticate beyond TNM. We just say stage 3, higher risk of recurrence, but beyond that, we really don't have anything else. And that's where ctDNA comes into play. A patient who's ctDNA positive has nearly 100% risk of recurrence versus somebody who's ctDNA negative. Their risk is much, much lower. So you can use this information to truly risk stratify and then make decisions about adjuvant therapy for these patients. The second issue is also we're still stuck with fluoropyrimidine and oxaliplatin as the only 2 drugs that we have in the adjuvant setting and nothing else, since the early 2000s. So the issue there is how we run adjuvant clinical trials currently. Thousands of patients over many, many years. And again, if we have a better prognostic biomarker that could really make these trials much more efficient, and with ctDNA, we're able to do that.
Absolutely, absolutely. So I think that's a great summary. So the way I do in my practice, as you said, if ctDNA is positive, if we look at the Reiner data, if we look at Galaxy study, if ctDNA is positive, the chance of cancer recurrence is close to 100%. So even if those patients are stage 2, so-called low risk stage 2, but ctDNA positive, I would bring up at least the discussion with the patient that your chance of recurrence is close to 100%. We should talk about adjuvant chemotherapy. Now, but I cannot go the opposite way, meaning if somebody is ctDNA negative, but adjuvant chemotherapy is indicated for that person by the current guideline, I will not skip the adjuvant therapy just because ctDNA is negative, unless somebody is very old, in 80s and frail, because we know that in older patients, doublet adjuvant chemotherapy could not show any survival benefit. So that's how I kind of try to use this information.
So 2 questions related to that. One, when you talk about you're checking ctDNA, when are you checking it? How far after surgery are you checking it? And then 2, are you using that for our stage 3 patients? For example, the IDEA trial showed 3 months versus 6 months of adjuvant therapy, but that wasn't looking at ctDNA. So do you use the ctDNA then to assess, do you check it right after surgery and then assess, does the patient need 6 months of adjuvant therapy? So first question is, when do you check it?
Wow.
Yeah, we generally check it. So we generally check it, at least within 4 weeks of surgery. I definitely don't check it within 2 weeks of surgery because there are a lot of, ctDNAs which are not relevant, like normal cell DNAs in the bloodstream. So after 2 weeks, so between 2 to 4 weeks, I think that's kind of our standard.
Yeah, absolutely. I think the paradigm, even up until a few months ago, was that you wait until 4 weeks or so to let the kind of post-surgical circulating free DNA to clear out. But there have been some recent data that suggests that up 2 weeks and beyond is sufficient to get a reliable reliable readout. I forgot what the second question was.
Second question was, do you use the ctDNA to assess whether a patient would get 3 months or 6 months of adjuvant chemo?
There are ongoing trials trying to determine the intensity of adjuvant chemotherapy based on postoperative ctDNA status. The ongoing Circulate trial is asking this exact question, where patients who are ctDNA negative are randomized to immediate versus delayed chemotherapy. So they'll be followed with serial ctDNA in the delayed arm and offered ctDNA adjuvant therapy when positive. Those who are positive are randomized between current standard of care, that is a doublet, versus triplet with the addition of irinotecan.
Anything to add?
It's a great trial, and I have to. So Arvind is very modest, so I have to call out that he's a national PI of that trial. So amazing study. Looking forward to the results of that. But yeah, I would agree. I think, and I would say the tissue-informed versus plasma-only question is also very important as far as timing. I do think you can, for a tissue-informed assay, you can probably get away with 2 weeks, 2 to 4. I think for plasma only, I would definitely wait till at least 4 weeks and beyond. I do think that sort of signal to noise ratio is definitely not as favorable there, and so waiting a little bit longer, you can eliminate some false positives. We have seen that in other trials, the COBRA study, for example, that false positivity may be an issue with plasma-only assays. So I think that's a very important distinction to make as well.
Great. So we're going to move to the next question I have, which is related specifically to some trials that I want to talk about, and then kind of we'll close with talking about the future and where we're going. So let's talk about FRESCO and FRESCO-2. Let's give a quick summary on those trials, and then how do we think that they impacted the way that you practice clinically? Who wants to take this one?
So FRESCO-2 is a randomized phase 3 study where patients who were refractory to the usual chemotherapy and biologics like FOLFOX, FOLFIRI, cetuximab, bevacizumab, or even a lot of patients received regorafenib and or TAS-102. So those patients were randomized to the experimental arm, which is fruquintinib, and best supportive care. And the placebo arm was placebo plus best supportive care. So that was a very vanilla design, phase 3 design, but very well conducted study because the patients were very well distributed across the arms. So that was actually amazing, how well all the risk factors were distributed between the two arms. And the study result has been published, and it shows that fruquintinib in that setting does improve overall survival, which is the gold standard of all the endpoints. So I think based on that data, FDA has approved fruquintinib in the chemorefractory setting for metastatic colorectal cancer patients who do not have like an actionable mutation. So that would be a different group of patients who have, let's say, HER2 overexpression. So that will be a different approach for them. But for 80% who do not have any actionable mutations in the kind of a third line, fourth line setting, I think fruquintinib is a new addition, which I think is helping our patients.
And I have to say, clinically, I've utilized it, and it's been tolerated very well as well.
Yes, very well tolerated.
One of my patients actually sent me a message on my chart and said, I don't actually feel like I'm on anything right now. Are you sure you're giving me a drug? So I think clinically, it's been very promising for quality of life as well. So that's been, anecdotally, at least in my patient population, I've been very impressed with it.
And the quality of life studies, along with FRESCO, that showed the same.
Yeah.
That it's a the drug discontinuation rate is so low, so that's less than 20%.
Yeah.
So that's another highlight of this study.
Which in the third line setting for these types of patients, I mean, that's something that I don't think we'd seen in a while.